Well, good afternoon, everybody. Welcome to SADS Foundation, episode number 98, I'm told. So it's great to get to be with you, either here in the afternoon in the United States or in the evening in Europe, or potentially, let's see, very early in the morning, almost 4:30 in the morning for my Aussie and Kiwi friends, where I just got back a week ago from an amazing trip down in Australia at the Cardiac Society of Australia and New Zealand, CSANS, and that's their equivalent of the American Heart Association meeting. And it was a fabulous meeting where we talked a lot about genetic heart diseases, like your genetic heart diseases. So welcome, everybody. I'm Mike Ackerman, genetic cardiologist and director of Mayo Clinic's Windland Smith Rice Genetic Heart Rhythm Clinic and the Windland Smith Rice Sudden Death Genomics Laboratory. But like the previous 97 times, I'm here today on behalf of the Sudden Arrhythmia Death Syndrome Foundation, the SADS Foundation, and our CEO, Alice Laura, who gives greetings and thanks for joining us at the SADS Foundation. I had the privilege of serving as president of the board for now many years, I think since 2006. In this episode, though, our focus is I guess, relatively new to the SADS Foundation properly, but those families and this genetic heart disease has been a welcomed addition and a wonderful addition, if you will, to the portfolio of genetic heart diseases that the SADS Foundation is committed to providing support, family support, meaningful education, and the like. And that is arrhythmogenic cardiomyopathy, or ACM. Many of our ACM families, they know of themselves more commonly as ARVC or ARVD, arrhythmogenic right ventricular cardiomyopathy. So whether you think of yourself as I have ARVC or I have ARVD, where the C is replaced with a D, cardiomyopathy for dysplasia, or if you now capture yourself under the umbrella term of the genetic heart muscle disease known as arrhythmogenic cardiomyopathy, or ACM, for which there are several specific genetic heart conditions that fall underneath that umbrella term, where ARVC is one of the ACMs, where the cardiac laminopathies, or LMNA mediated ACM and the like. And so we're focusing on your disease for those families who have this one. For our families out there with other genetic heart conditions that make up much of SADS Foundation, long QT syndrome, CPVT, Brugada syndrome, and the like, you are always welcome. There's always information that cross covers, but remember, as we've talked in the past, some of the things that we may be speaking about today with respect to the specific genetic heart set of diseases called ACM, and specifically ARVC, they may or may not apply to your specific genetic heart condition. So I'm getting a thank you from Christy, and you are so welcome. We're so glad to add ACM to what the SADS Foundation is committed to, and indeed, we are very, very committed. And since this week and this session is devoted to the ARVC, ACM world, I couldn't think of anybody better than somebody who's becoming a very good friend, special guy, Dr. Harikrishna Tandri from the Johns Hopkins ARVC program. The Johns Hopkins ARVC program is a destination center for specialty care, particularly for ARVC, like we are at Mayo Clinic for all of the sudden cardiac arrest predisposing genetic heart conditions, which include ARVC. So Aaron's going to bring Dr. Tandri, up to join me, and then we are going to start delving into your questions. And welcome to SADS Foundation podcast, SADS Live, number 98, Dr. Tandri. Great to have you.
Thank you. Thanks, Mike. Thanks for a fantastic introduction. It's been a great pleasure working with the SADS Foundation, and I'm thrilled to know there's already 98 done, too close to being a century, a big gala celebration, I'm sure. Um, so as Mike mentioned, I work at the Johns Hopkins ARVC program. I co-direct the Hopkins ARVC Center, and mainly focusing on catheter ablation of arrhythmias in ARVC or arrhythmogenic cardiomyopathy. I started my journey quite a long time ago. I was just telling Mike it's been 22 years at Hopkins. But before that, I graduated from India in 1995 and spent 4 years in the United Kingdom practicing internal medicine and cardiology before I came to the United States. I was in lookout for a good research project to start my career as a cardiology fellow, and I was offered this great opportunity of understanding a rare disease. I remember those days when Hugh Hawkins was telling me about this rare condition, saying that no one knows a lot about this condition, and if you spend a lot of time, you could be an expert in it. And I wasn't really sure what he was talking about, but 22 years fast forward, I exactly know what he's talking about. Really, I think I spent the earlier years of my cardiology fellowship trying to understand the anatomic details of how the ARVC affects the heart muscle, especially using MR imaging as a way to look at these arrhythmic cardiomyopathies. And soon enough, we were writing the literature on imaging findings in ARVC, and we gradually transitioned into a full-scale center which caters to almost all aspects of the disease, right? Starting from the diagnosis to understanding the needs of these unique population, including the athletic nature of these, the high achievers, and all sorts of understanding that this population needs a totally different approach to both diagnosis and care and management. And eventually, when I joined faculty, I started the VT ablation program for ARVC here, and spent pretty much last 10 years perfecting that part of the program, including sympathectomy, slowly coming into Mike's territory of CPVT. So I think we have over a period we've built a very comprehensive clinical program integrated with research, trying to understand ARVC and how to make the lives of ARVC patients better and close to leading a near normal life. So that kind of
Dr. Tandri, yeah. So from India to the UK, and then now the last 22 years in Baltimore, and then becoming a really not just a heart rhythm specialist, but really an ARVC specialist. What drew you back then and still excites you now about this particular cardiomyopathy?
There's several aspects of this myopathy. It's super interesting to me. It's just that again, as I mentioned to you, that the needs of this population is very, very different. They want to go and do stuff which is totally different. I keep telling my patients, most of them, if you take other types of cardiomyopathy, we are really getting them to do things, to move and do whatever. Here, it's a totally different thing. You're trying to hold them back, asking them not to do things and whatnot. It's really important for me to understand, how exercise and athletic activity kind of integrates with this disease. Does it, what's the role of all of them? That really has excited me all along. To that end, I slowly started looking into the autonomic nervous system and its role in arrhythmogenesis, and that kind of opens up a whole new doors of understanding the beauty of autonomic nervous system is it's multi-system. It's like you can stimulate the earlobe and affect the heart. It's such a fascinating thing. It makes you wonder about the miracle of the human body itself. It's been such a great pleasure learning about this condition and then transforming that into understanding human biology itself. So that's what really excites me.
And I wonder, we have some questions starting to come in. And Marie, hello from Kingwood, Texas, and great to have you. And Christy, again, we love having ARVC and ACM in the SADS Foundation family. And Stacy, you're very welcome. And Heather, you're welcome. So we love doing this. I wonder, Hari, one of the questions that comes up a lot, you said it's rare. do we even have a very good handle on the epidemiology, the frequency of this entity? And again, not sort of all ACM, but maybe desmosomal ARVC proper. I mean, I think in long QT syndrome, because of the work of the great Peter Schwartz and others, when we say it's about 1 in 2,000 people have congenital long QT syndrome, I would say we're pretty rock solid on that number. If we think of hypertrophic cardiomyopathy and from the echocardiography studies, and we say or suggest about 1 in 500 people have maladaptive heart muscle thickening, also known as hypertrophic cardiomyopathy or HCM, that seems like a pretty solid number. But then we come to ARVC, and the numbers we quote as to how uncommon, rare this entity might be seems on soft, squishy data. What's your best sense of where ARVC is in terms of incidence?
I think it's a difficult question. As you said, there is really no good data on what's the actual incidence of ARVC is, or even if you take a population prevalence of how many people actually have desmosomal mutations, that means something. I don't think people have studied that carefully. There are certain endemic areas, like Italy probably has a much higher prevalence, and they quote 1 in 500 based on some publications, but really, again, the source data aren't really existing on how you can verify that. I think in ARVC, the problem is twofold. One, even when the disease is early in its manifestation, we are having trouble actually diagnosing it, even using the exact phenotype, because a lot of things that come along with the disease, slight RV dilatation, T-wave inversions, are fairly common across the population, so it's kind of hard to nail down the phenotype. That's one problem, trying to diagnose the disease. And things that were called probably variants in the past have turned out to be disease causing down the road. So we really don't know what are all the different desmosomal mutations which can affect it. And then you have to add these factors which are in addition to that, like environmental factors and personal factors, which again cause the phenotypic expression of that genotype. So that is what really makes it complex to understand the epidemiology of this condition. But I agree with you, it's probably the prevalence is a lot more than what we understand. And only the tip of the iceberg is the patients presenting with symptoms, then we actually have to.
Do you think it's reasonable to think about it, at least in North America, in the 1 in 5,000 territory? I just don't think it's as common as long QT. But what if you were forced to put a North America incidence on it? What would you even suggest?
I would stick to that order of magnitude rather than 1 in 500 or whatever. I would stick to the 5,000 to about 10,000 would be the right prevalence of the genetic mutation, not the disease itself. Yeah.
Well, let's jump into some questions, because there's some great ones that have just come in, and you've done so much in the therapeutic spectrum of ARVC, and I think we'll be discussing your thoughts on medication management, anti-heart rhythm medications, but the role of ablation. And this one sort of, I think, launches us into that. And BJ is asking, after 22 years on the medication Sotalol and having a device, I'm assuming a defibrillator, without any events, just recently went into VTAC. Says his device didn't correct it. I'm not sure what that exactly means, but he's wondering, could the Sotalol be becoming ineffective, or has his ARVC gotten worse? What say you on that, Hari?
It's very common for people to have arrhythmias far out from the initial event. For instance, even patients who have heart attacks way back in the, like say they have a heart attack way back in the 90s, it's common for them to present 20 years later with VT. It's not that their infarct got worse, it is just the conductive properties of the heart change with age. So when you come to the right stage of your life where the conductive properties of the surrounding tissue and the scar are perfectly conducive, that's when you develop ventricular tachycardia. It's not like suddenly that your heart muscle is giving up or getting worse. So because it's purely dependent on electrical properties of conducting media and also the scar tissue, so the VT can occur a little later than when the insult actually happens or when the scar actually happens. So I don't think it's the sotalol suddenly becoming ineffective. It's just that the conductive properties of the tissues are changing over time. And that, if you appreciate that, then that makes sense on why it would occur at a later date.
That's great. And then I'll give you, well, as you know or have come to know, the SADS families are unbelievably sophisticated. So they don't really give us any what I would call lobs over the plate for us just to knock out of the proverbial park. Translated easy questions. Their questions are really good and they're not easy. So here's an easy one. Not. Daedra is saying, would you implant a defibrillator on a newly diagnosed ARVC patient at this time? And that probably begins a can of worms to get open, because there's a lot that you and I look into, deliberate over before we make an ICD decision. Of course, if they've already done a death attempt with resuscitated cardiac arrest, you and I still really have no choice but to put in a defibrillator, which is actually quite different than a cardiac arrest survivor due to CPVT or LQT1, where we may in fact be quite comfortable without the ICD. I don't think any of us are comfortable without the ICD after a first death attempt. But what about the asymptomatic person, newly discovered, just been told they have ARVC? What are you looking at to try to decide their weather forecast as to whether or not they should get a defibrillator?
Right. So that's actually a great question. It's something that we go through almost every day when you diagnose somebody new with ARVC. This is something that goes through your head. Clearly, someone who has a very active Holter. So if you do a 24-hour Holter monitor and they have lots and lots of PVCs and non-sustained VT, it is a marker that they will develop sustained VT down the road, right? Not sudden death, but they will definitely develop VT down the road. But then it is dependent on your level of hydration on that particular day, whether you will pass out or not, or whether you have hemodynamic instability or not. So in general, when we see lots of non-sustained ventricular arrhythmias on a Holter monitor, we advise getting a defibrillator. The second thing is presence of severe right ventricular dysfunction. It also is something that is commonly goes along with the occurrence of VT during follow-up. So we usually look at that as well as a way to advise people to get, defibrillators. Prior history of syncope, for whatever reason, you've had syncope, it's hard to explain or connect the dots, even though it appears like vasovagal syncope by history. If you have ARVC, we generally put two and two together, saying this is probably an aborted sudden death, and we do advise defibrillators. And beyond that all, if you have a very strong family history of multiple siblings having cardiac arrest or whatever, that's another red flag that your mutation is probably highly pathogenic and probably has a high risk of VTVF. And finally,
there, could I pause you on that one a second, Hari? So family history, because we have a lot of different families here in the SADS Foundation, and that's part of the very beginning. I said maybe what we say for this condition may not apply to other conditions. So for example, we know that family history, as tragic as it may be, doesn't really tell us that much about the patient in front of me when the disease is called long QT or CPVT. But it does if the patient has HOCM or hypertrophic cardiomyopathy, where family history still is one of the big three risk factors. Where is the strength of family history, do you think, in ARVC? You did say that a family history of sudden deaths because of ARVC is a risk factor in ARVC. Is it as strong as you think family history in HCM, or where would you put the strength of that signal?
So that's a great question. So if you look at the data, actually published data, family history doesn't really rank high in ARVC. We always look at syncope, non-sustained VT, and whatever. But if you actually look at clinical practice and how we look at things, there is clustering of behaviors within the same family. There is athletic activity that clusters within the same family, the same mutation, and often when you see a brother or sibling having an aborted sudden death during exercise, you notice that the other sibling has the same phenotype and also has the same type of tendency to do a high level athletic activity and all sorts. So it makes common sense that they share the same mutation, same structure. But that being said, the diagnosis should be met in those conditions. They should meet all the task force criteria, have structural disease, and so on. So in that setting, it mirrors so much about HOCM, because HOCM is also a phenotypic disease. It's just a mutation. It's not like long QT or CPVT. So I would say that having that information is important. I wouldn't cast away that, because right now there is no strong connection between family and that. I would just use that.
Yeah, and I think there it's kind of the important, I think you really nailed it with, we are seeing this, and that's why I wanted you to touch on it, that if a person has a positive ARVC genetic test only, and their cardiac tests are normal, but there was a family history of death, we shouldn't be throwing in defibrillators in that person because it's only the positive genetic test, even though there's, quote, family history. Would you agree with that?
Yes, definitely.
Yeah. Well, here's a really, they want to know more about therapies and where are we in the future with gene therapy. And Karen's asking about her son, diagnosed a year and a half ago. I don't know the age, after first heart attack. So let's assume sudden cardiac arrest. But the ARVC structurally is progressing much faster than the care team has anticipated, got the defibrillator, and saying that the next step appears to be heart transplant on the horizon. The team is saying not ready for transplant yet, but feel that it is in the probably sooner than later. Karen's wanting to know if there's any hope for a cure in the near future that is not a heart transplant. So I'm going to have us break this apart a little bit, because there's a lot there to chew on. First, in your large ARVC destination center practice, what % of your ARVC population has received a cardiac transplant?
So I think in a cohort of over 2,000 patients that we're following, I think we have about 30 or 40 patients who have received heart transplants. It's a very small proportion of the entire cohort who actually need heart transplant. And I would say that most of the patients have had quite severe RV or LV involvement at presentation. So it's not like present with healthy hearts and over a period of time develop progressive dysfunction. It's just that when they presented, they already had severe cardiomyopathy during presentation.
Right.
That's an important thing to remember.
So it sounds like Karen's son is kind of like that, and I agree. It's probably in the 2 to 5% range of an ARVC population, especially a tertiary care like yours or ours that gets a transplant. She's asking near future, so I would just put out for you, Karen, that if they're already contemplating transplant, there's no way that we are on a time horizon where the advances that are being made in novel therapies are going to come soon enough for your son. So I think that's a dose of reality for the community out there, because we're excited about gene therapy and other therapies, but there's not going to be that excitement delivered, even if everything works, for, I would say, minimum 3 years. But what's your sense, Hari, on the landscape of the pace of a new therapy advancements for this? Maybe touch on any gene therapies that are in motion, any gene therapy trials, and are you more optimistic about the time frame, or think that even 3 years is being quite optimistic?
I think it is being quite optimistic, in my opinion. I think the first wave of trials will be in looking at tangible outcomes, such as preventing recurrences of ventricular arrhythmias or reducing ICD shocks and so on, because they are more measurable and quick endpoints that they can achieve or any sort of a clinical trial perspective. Progression and preventing progression is a very, very long track to show a significant difference in using gene therapy. So for that reason, I would say that those trials will be starting at some point, but the results won't be available for several years. So I think that for cardiomyopathy progression, it's a little longer road. For arrhythmias, it may be shorter, but I would still think it's more than 3 years.
Yeah, I agree. And one of the questions comes about from Catherine for gene therapy. Has PKP2 specifically, so anything that you know of about possible PKP2 therapies, and would such a therapy, gene therapy, be appropriate for somebody who has the disease, has the gene, obviously, or someone like her brother who has the PKP2 mutation but does not show the disease? And there, Catherine, we will never be doing gene therapy for the near future for those who don't yet show the disease, because we don't even know whether that person is going to convert or not. But what about Catherine, for Catherine, Hari, on, is there a PKP2 trial in development? Is there anything that can be shared with the community about what's the state of that one?
Sure. I think the first trials are going to be in PKP2 mutation only because it's probably the most common one in the United States, and several of these patients have been carefully phenotyped. So I think the first trials will start in PKP2, but I think Mike's right, Catherine, that's probably not going to be for asymptomatic people. It will be for people, patients who do have some structural disease, some ventricular arrhythmias. That would be a good starting point. And also, I don't think they'll pick a very high risk population either to do gene therapy. So it kind of will be in the medium intermediate population will be the first goal.
And Christy has a great question, and it follows. I just said that there's no way that we'll know whether or not a specific person who inherited the family mutation, whose tests are normal, will convert the next year, 5 years later, 10 years later. But how accurate is that statement about penetrance? Do we have any sense of being able to tell a family what's the likelihood that their positive genetic test result is going to give us a heads up that they will show the family disease in 1 year, 5 years, 10 years? Or is it really a, yes, you own the mutation, but we're just going to have to keep watch on you every so often to decide or to determine whether you're ever a converter?
Yeah, that's a great question. I think the negative predictive value is great. Don't have the mutation, you're good.
Yeah,
Once
that's
you have
great.
the mutation, it's very it's like a hand wave. If I'm going to tell you in 1 year or 5 years you will develop something, the good news is that once you know that you have a mutation, there is a subtle change in behavior which prevents you from getting the disease in the first place. There are a lot of patients basically they alter their behavior in one way or the other. So in our cohort, what we have seen is that once you're with the program, you have the mutation, you know you have the mutation, you're watching yourself, your level of athletic activity is slightly curbed. Whatever it is, I think new structural disease is very rare. You come in with what you have, and it's also that if you're quite a 40 or 50-year-old and you've been told that you have the mutation and you have no phenotype to show for, I think that's pretty good. It's very, very unlikely that you will develop something new from that point on, and we have not seen that as well. So I think it's important once you know that to see where you are at that time, and if that is good, I think most likely if you are over the age of 20, I think you're okay. But what we recommend at this point is to check on every 5 years or do a Holter and an echocardiogram. And by the time if you get to 40, if you don't have anything, I think you can be reasonably sure that you haven't got the phenotype.
Yeah, great. And we have 10 minutes, believe it or not, only 10 minutes left on the counter. And there's so many good questions, but I am going to give you a lob because this one is right in your sweet spot, because you probably know more about this topic than anybody on the planet. And that is, what are your criteria for when to do an ablation for ARVC. And so speak a little bit about the role of ablation, but then more directly as you come to learn, because I think you really, and I do mean it, I'm not tickling your ears. I think if you were to ask who knows the role of ablation the best in this specific genetic heart condition, I think it's a person named Dr. Hari Tandri.
Thanks, Mike. That's a great question about when do you do VT ablation. I would say that if you do have VT, if someone with ARVC has documented ventricular arrhythmias, ventricular tachycardia, it is always good to have some way of mitigating that before you put a defibrillator. So usually the previous teaching for a long time was that if you have VT and if you fail drug therapy, if you get ICD shocks, then you go do a VT ablation. Over the course of dealing with patients for over 10 years, I generally believe that ICD shocks are in general bad. It's great to have a defibrillator as a backup, but that is the way it should be. It should be used like an insurance policy. It's like, I keep giving this example to a lot of patients who come. It's like if you have a house that's burning, you don't go and buy an insurance policy. You first put out the fire, then you buy the insurance policy. Similarly, having a device really means that you're really protecting yourself from ventricular fibrillation, not from VT. And ventricular tachycardia should not be exposed to ICD therapy. So I have changed my thinking over the course of last several years, and we are quite, I would say, aggressive. We're quite, realistically approaching this problem, saying that if you have VT, we usually like to treat the VT, then put the defibrillator as a prevention for sudden cardiac death. And I also say this because the technique of VT ablation has evolved so much over the last years. It is super safe. I'm sending patients with epicardial VT ablations the same day, like an outpatient procedure. We really drummed it down to a set of rules that we practice to be extremely safe and methodic about this. So and success rates are also pretty good with VT ablation, and especially good in ARVC, even compared to sarcoid or any of the cardiomyopathies. I would say that it's an early approach for now compared to the previous times.
Yeah. And of course, you probably agree that if they have a defibrillator and if they do have a correct shock for VF or VT, that is sort of one strike and you're out, as in one strike and it's time to see, should we do the ablation to try to prevent the future shock?
Sure, absolutely. I think so. The intention or the enthusiasm to actually go and do something is highest after the recent shock or a recent therapy, and slowly fades away until the next episode happens again. So in general, whenever patients have an ICD shock, it's very important to address that aggressively and usually consider a catheter ablation procedure to avoid the next shock, because as I mentioned before, it does have a very negative impact on quality of life.
Right. Absolutely. And I think any of the families should reject the notion that if the person tells them that's why you got the defibrillator, it worked, get out of here, that's the wrong person, because you and I view a shock as a call to action, right, rather than a pat on the back saying that's why you got the box.
Right. Yeah. I completely agree. Yep.
Well, we could devote the entire episode to Georgie's question. And it's probably not fair for the last 7 minutes, but we're going to do it anyway. We're going to go there. So here's the stage, and he does a nice job, he or she, of setting it for us. 27 years old, 9 years of a heavy gym working out. ICD has fired 2 times, 6 total, in a span of a month last year prior to an ablation. Now having non-sustained VTs breaking through the meds, but nothing more than that. And the question is, as you can imagine, will I ever be able to return to bodybuilding? PKP2 positive, normal RVEF, just the arrhythmias that we just described, on medicines, interesting set of medicines, amiodarone, mexiletine, and bisoprolol. I guess we won't critique that for a moment. had an endoablation and so forth. But regardless of how he's been treated, I think maybe we might start to say, before you and I let any of our ARVC athletes return to sport in any way, we've got to be completely satisfied with our treatment program. So let's say you and I were to be satisfied with it. And I'm only putting it out there, Georgie, because I have a feeling that both Dr. Tandri and I might be wanting to tinker a little bit with the treatment configuration. But we'll leave that. But instead, we're just going to say, Hari, you're pleased with your patient's treatment, and he or she wants to be a bodybuilder or return to bodybuilding or return to a non-endurance sport. Where are we now in this phase of what we let the athletes do or do not do once they get nailed with the diagnosis of ARVC?
I think I'm quite lenient with the non-endurance part of it. Like usually bodybuilding, lifting weights and all, which is fine with me. I just say, do what you need to do, and we'll follow you annually with, Holters and echocardiogram and see if there's any change. And if there's any change, we'll let you know, we'll change behavior. Otherwise, you do what you need to do, because I think in the end, that defines the quality of life for the patients. And taking that away is the same thing as putting them on amiodarone or mexilidine. It's taking that away becomes a significant impairment to their quality of life.
Yeah,
I don't have a problem with that. And it has to be closely watched. If that exercise behavior leads to VT, then you have to correct that and get them back to where they are, and be sure that you're dealing with that part of it correctly. But if you take that question and spin it and say he wants to run marathons, then I would still say it's a shared decision making. You will tell them that we advise you not to do that, because that is how we believe that this condition gets worse, and you can provoke more arrhythmias and ventricular dilatation and so on and so forth. But if you still want to do it, then do it at understand the risks that you're getting into. At the same time, we need closer follow-up. We'll keep, we'll watch you closely. We'll check on you periodically with echocardiograms and see how things work, and let you move forward with that.
Yeah. There's so much there, and maybe we have a whole session in the future devoted to this topic of shared decision-making and sports participation. But I will add one to end with, because I think we have a new question swirling around. In episode number 1 of SADS Live, the very reason we started it in like February of 2020 is because this thing came about through the United States called SARS-CoV-2 infection, also known as COVID-19. We didn't know anything back then, 2.5 years ago. There was tremendous fear in the SADS community of, will the virus agitate my heart disease? Am I at high risk? Will the disease infection be worse in my body because I have a genetic heart condition? Should I get to the front of the line when vaccines come out because I'm a high-risk person? And I think we pretty accurately called it, and we're right, even before we had all the information, that no, the disease is not going to get worse if you get the infection or if you get vaccinated, and you're not high risk, meaning if you get the infection's not going to be worse in your body because you have long QT, ARVC, CPVT than in my body or your body where you have nothing wrong with us. But a new thing is kind of bubbling around, saying that ARVC patients are having more episodes during this pandemic because of either the virus or the vaccine. And I think this is fake news. I have not seen this in my own practice, but if anybody has seen it, it would be you and the Hopkins ARVC Center. Do you have any signal where you think the ARVC disease is progressing more rapidly during this 2 years than, say, the 2 years before we even heard about SARS-CoV-2?
Not really. I think that's clearly fake news. In fact, the people have done excellently during this year has been our ARVC folks. For whatever, maybe they've stayed indoors or whatever it is, we've seen that they've dealt with the whole epidemic fantastically, and a lot of patients got COVID. They did have COVID and whatnot, but had very minimal symptoms and just flew through it. It's just they behave like what young people do, just not have any symptoms and just breeze through the COVID pandemic, but no arrhythmias or no worsening of any sort.
Right. Well, we've come to the top of the hour, and like our previous times together, Hari, thank you. I really appreciate you taking the time, your partnership with us at the SADS Foundation, your dedication to the thousands of patients who you care for at Johns Hopkins, and what you've done there to advance the ARVC state of knowledge like no other single institution from my vantage point. So thank you, sir. Thank you very much. I can't wait for our next chapter together, and I hope you'll come back and join me for a future SADS Live program. All the best to you.
Thanks, Mike. I really appreciate you having me here. Thanks for the SADS Foundation and the family, SADS family, for having me on this show. Really appreciate it.
Great. Take care. And to all of you out there in SADS Foundation Live land, be well. Have a wonderful rest of the summer, although it's going by fast. We'll be together for SADS Live number 99 in 2 weeks on the Friday just before Labor Day weekend. So I know where I'm going. My granddaughter just arrived about an hour ago. She's napping right now, as is, let me see, my dog program is finished. And so finished we are, and see you next time. Blessings, everyone.